And I'm sorry, so I'm just gonna start with that. I tried to bring out on the slides, if it's not, because I don't know that they're that way in your text, in your word guide, they might be bolded, I can't remember. The parts of the words that are the same to make it a little bit easier to remember them as groups, so that you can kind of think about those groups in your mind. And remember, you kind of just need to memorize the group information for the most part. So, first one is insulin stimulators. They end in the "ide." It includes the sulfonylureas and some meglutide analogs. They actually stimulate insulin secretion. There are a lot of drug interactions, especially with the sulfonylureas. So you need to be sure your patient is carrying a med list with them and telling everyone who prescribes to them what they take for their diabetes and what other medications they're already on. For these, hypoglycemia is a major side effect. So, and they need to be taken with or just before meals for that reason. Nausea, headache, and weight gain are the common side effects. So tell your client that up front, because side effects are less stressful when they know that's what they are and where they're coming from. They are nausea, headache, and weight gain. They stimulate insulin secretion, yeah. The next class is pretty much just metformin. Does not stimulate insulin secretion. It actually works by decreasing glucose production in the liver and decreasing absorption of glucose in the intestines. Okay, go ahead. Okay, so Jeremy's question is, would it be counterproductive in the long run? And that might be true, but I mean, I see your point that it might contribute to that, but basically it's providing, yeah, but it at least controls them for a period of time. So, and it can also, different meds work on different people better. So if they are still kind of capable of producing insulin, it might be enough to help them out. Okay, so metformin, that last medicine there, does not stimulate insulin secretion, decreases glucose production from the liver, decreases absorption in the intestines. So it is, and then the other really important thing to remember about this one is that, it's a good first med for people, it's low cost, has a low side effects profile. The thing that's important to remember about it is it's kind of hard on the kidneys. So if there's anything else going on, like they're having a procedure with contrast, or they're having a surgery where they're gonna need their kidneys to filter out that contrast medium, they're gonna need their kidneys to filter out their anesthesia, then they need to be off of it for 48 hours before and after the procedure. And the risk from the kidney damage is that they'll get lactic acidosis. Alcohol will also increase the risk of that. So it's best if they avoid alcohol in this medicine.
Of what?
The common side effects that you should tell your client about are, you guys ready?
No.
Not ready? Okay.
Acidosis, I'm not sure they're familiar with that.
Oh, okay. It's basically just an increase in acid. The most important thing for me is the nursing implications of it right now, just because there's so much in this lecture already. So just know that they need to be off of it, because if they're taking anything else, it's gonna stress their kidney out for 48 hours before and 48 hours after procedures. Side effects are diarrhea, nausea, flatulence, indigestion, and abdominal pain. Right, decreases glucose production from the liver and also decreases absorption of glucose in the intestines. Well, right, yeah. That's why you get so many GI side effects, true. Next set. These are the ones that end in glitazone. These are insulin sensitizers. They increase the ability of the cells to use the glucose that's already present. So by doing that, they improve cell function and decrease glucose in the serum. Risks that are inherent with this medicine include cardiac-related death, fractures, and they can increase macular edema, which remember is one of those vision changes we already have in diabetes. So. Cardiac-related deaths, risk of fractures, macular edema. Oh, what do they do? Increase the ability of the cells to use the glucose that's already there. Make them more sensitive. No, you're fine. They have a black box warning because of some specific cardiac issues, including heart failure. So for that reason, for these clients, you want them to weigh themselves daily and report significant weight gain if it's more than 2 pounds in a day or 4 pounds in a week. Because remembering back to Mr. Bragg's lectures, that's probably a fluid issue and not a caloric issue if it's happening that fast, and so we need to deal with it. They need to report any vision changes, and they need to take fall precautions because they're going to fracture more easily on this medicine. The next ones are alpha glucosidase inhibitors. They unfortunately do not end in the same thing, so those you're just going to have to memorize. What these meds do is they slow down the intestinal breakdown of starches into glucose. So basically they're going to kind of even out glucose absorption because they're slowing down that breakdown. So you're not getting that big spike. If these are used by themselves, they cannot cause hypoglycemia because all they're doing is slowing the digestion. So they slow down the breakdown of things so that they're not, so your intestines aren't absorbing glucose as quickly, basically. So it kind of evens it out and decreases that spike. But for that same reason, hypoglycemia is actually not a concern with these unless they're on something else with it. Because it works in the intestinal tract, it has to be only taken with meals. So it's not necessarily like timed, like you're gonna take it at 12 and 2 and whatever, you're taking it when you eat, basically. Or the timing is based on the meal time. For these particular meds that the client doesn't eat, they shouldn't take the medicine. That is not true of all diabetic meds, but for this one, because the specific action is on the food that they're taking in, then there's not really any point in taking it if they're not taking the food. And once again, because it's an intestinal effect, it causes intestinal side effects. So the same kind of thing, abdominal discomfort, bloating, gas, nausea, diarrhea. I'm more worried about just classes with these. But because you're right, because that is how I've done it at times. But she was asking about prototypes, and I'm more just worried about you kind of know what goes into class on these, and just kind of this broad information over them. Incretin mimetics, they mimic the effect of natural digestive hormones. And by doing that, you don't have to write these down and memorize these. They limit glucose production from the liver, reduce secretion of glycogen, and slow digestion, all of those things. These all end in tide, as you may have noticed. These do have a risk for hypoglycemia then, because they're actually acting on glucose production, glucose secretion. These are only available as sub-Q injections. And it's important for your patient to know there's an extended release form that is weekly, but there's also a daily form. And it's important that your client knows which one of those they're on so they're not accidentally taking something that they should do weekly, daily. The major risk with these is pancreatitis. So if they're having any kind of jaundice, yellowing of their eyes, things like that, they need to report it, or any kind of intense abdominal pain that radiates to other areas. Because we talked about with pain, visceral pain tends to radiate to other areas, so their flank, their shoulders, things like that. Could be signs of pancreatitis on this med. Thanks. Maybe it's the last page of diabetic meds. It is. Okay, so the next section are the ones that end in gliptin. And basically these work by, this one's a little bit complicated. They inhibit the breakdown of the normal hormones in the gut, basically. So they allow the hormones to work longer. Basically, they have similar effects to the mimetics that we just talked about, except instead of mimicking the effect, what they do is allow them to work longer by not letting them get broken down. Similar risk factors too, they can cause hypoglycemia. Same issues with pancreatitis because they basically work in the same way, just they have the same effects, work in a different mechanism, but have the same effects. So both of them can cause pancreatitis. This one in particular, this group, allergic reactions can be common. So you need to educate your client about what an allergic reaction might look like and that they need to report that so they can get switched to something different. Amylin analogs, they work by decreasing glucagon, slowing gastric emptying, and they also trigger a full feeling so that the clients don't actually consume as much. They work by, I'm just not gonna read it or I'll say it wrong. Decreasing glucagon, they slow gastric emptying and therefore digestion. And they trigger a feeling of fullness for the client. They do carry hypoglycemia risk. They're also a sub-Q injectable, so your client needs to know where to put it, what to watch for, like, not to, if it's swollen or hard, you've got hard knots or anything, not to inject it, same kind of stuff you teach them about in phone. Common side effects are nausea and vomiting for that one, which would make sense because you're slowing down their digestion. The last one, sodium glucose cotransport inhibitors, those end in glufocin, I can't say it today. They prevent kidneys from reabsorbing sodium and glucose that have been filtered in the urine, so they increase the excretion of those. So, from reabsorbing sodium and glucose, so those things go on out, basically, instead of reabsorbing a portion of them. So hypoglycemia is going to be a risk because of that, but then also dehydration. Talk about what do we look for dehydration? What kinds of things are we assessing for? Dry mucus membranes is good. What else? Scan urine. Although in this case, it might be urinating quite a bit, so they're getting rid of all those electrolytes. But yeah, as it got further, their urine production would start to decrease. Decreased skin turner is good, yep. And then kind of hypotensive effects, increasing pulse, lowering blood pressure, orthostatic lightheadedness, things like that. They can also lose too much sodium on this med. So they could develop hyponatremia also. And one last thing with that med, they have an increased risk for UTIs because they've got all that extra sugar in their urine and yeast infections. So with that extra growth material for microorganisms there. Then there are lots of different ways to combine those above meds, and they can be highly effective when you're combining those different mechanisms together, and you may want to combine them with insulin also. Okay, past that part. This next slide is just, there's a lot to it. Okay, I added one thing to the bottom of this one. I added foot care, but it's going to have a separate slide too, because somehow I totally left that out of these slides when I made them. So as far as teaching, some of these things we've kind of already talked about. So monitoring, we've talked about a little bit already. One of the things we haven't talked about is proper hand washing. It is an infection risk that they're sticking themselves all the time, so they need to keep their equipment clean. They need to not share their equipment with other people, wash their hands before they stick themselves, don't reuse the lances that they use to stick themselves, kind of common sense things, but remember, they don't know infection control like you guys know infection control. If their readings are outside of their target plan for 3 consecutive days, then they need to contact their provider and determine if they need to be changing something. If their readings are outside of their target range for 3 days in a row, they need to contact their provider. And keeping in mind with that, the nutritional changes are sometimes preferable to medication changes, because if we keep increasing the insulin to deal with excess calories instead of actually making the nutritional changes, then their weight gain is just gonna get worse, and we're gonna perpetuate the problems we've already got. So nutrition is always our first, our first assessment, our first attempt is always nutritional. Fingertip readings are the most reliable, especially during times of rapid changing levels. There are some newer machines that will do capillary readings, but those are kind of slow to react. So if you've got a client that's sick, you definitely want to do fingertip readings to determine your actions. Use those because those are going to be the most accurate. Nutrition. You should always consult a dietitian in the care of your diabetic clients, because they can help them develop an individualized meal plan that takes into account their personal preferences and things like that, and make them more successful in their nutritional management than we tend to have the time and expertise to do. So nutritional plans for these clients need to be flexible, realistic, take in cultural considerations. Teach your clients that consistency in meal amounts and timing increases their ability to manage their glucose levels. So if they can eat at consistent times, eat a consistent amount of food. If they're eating weird times, eating huge amounts followed by small amounts, obviously it's gonna be really hard for us to adjust any medication to deal with that and get a consistent level of control. Current research does not support giving the client specific percentages in terms of guidelines for foods. So you want an individualized plan that's making healthy choices, but don't tie them down to numbers necessarily. Their protein and fat intake are gonna have little effect on their glucose levels. Although fat intake is gonna influence cardiovascular risk, obviously, but carbohydrates are what you're primarily concerned with. We wanna limit simple carbohydrates because those break down quickly and lead to spikes rather than steady breakdown. We want to tend towards carbs that have some nutritional value. So we want the carbohydrate to be of value. So basically, fruits instead of saltine crackers, things like that. So highly processed, simple carbs typically don't have a lot of nutritional value to them anyway. So we want their carbs to be worth something when they eat them. We also want their carbs to contain fiber because it breaks down more slowly. So when they're eating whole, the same reason that eating a carrot is better than drinking carrot juice, basically, is that it's going to break down more slowly and give them a steadier level and give them fiber along with it. Obviously, we want them to avoid sugar-sweetened beverages like sodas, sweet tea, fruit juices, things like that. Sometimes that's a conversation you have to have with people because they think fruit juice is healthy because it's made of fruit, but juice isn't necessarily a good thing for them. Fat intake we kind of talked about, so we're going to limit that mostly for the cardiovascular issues related to it, not necessarily for glucose control specifically. So we want them to take in higher quality fats, less of the saturated, more of the unsaturated. You may want to limit sodium intake to limit damage if they've got hypertension. Their alcohol, any kind of alcohol consumption will affect their glucose levels and needs to be taken into consideration in insulin dosing. If their glucose is well controlled, then moderate intake should not be problematic. That is, again, 2 for a male, 1 for a female on a daily basis. The important thing for them as diabetics is they need to, and I think we might have touched on this Tuesday, they need to eat it with a meal or immediately after a meal to prevent getting hypoglycemic later. So they should not ever be drinking at bedtime then going to bed. Be sure that you're including whoever buys, preps, plans the meals in any kind of education. So if you're talking with a man and his wife is the one who's going to do all the cooking, or vice versa, either way, you want to include that support person who's really going to be the one that, because they're probably going to eat whatever's prepared for them. So that person needs to be involved too in the planning. They will need to adjust their intake when they're ill, and we'll talk about sick day rules here in a little bit, or when exercise is planned. And that brings us to exercise. So physical activity is good, helps us improve glucose regulation and controls weight, thereby decreasing the potential for complications. However, it can cause hypoglycemia if we don't plan it carefully in terms of food and meds. So on a day that exercise is planned, insulin dosages can be reduced. If we have an unplanned exercise event, then they may need a snack to offset those extra calories that they've burned. Clients need to understand their medication regimen and when to best plan or avoid exercise. It's best for them to exercise immediately after a meal, but not within 1 hour of an insulin dose or during the peak of their insulin. So you're going to look at those insulin, what kind of insulin they're on, what time it peaks, and help them find an exercise time that will not be during their peak when they will just consume some calories. Because basically when you think about it, if they don't have enough insulin in their system to move glucose into their cells aren't going to get any food basically when they try to work out, and it's going to make things worse. So before they exercise, they need to check their finger stick. It needs to be between 80 and 250 for them to exercise. If it's been more than 1 hour since they ate, or they're gonna do a high intensity workout, they will need a snack before they eat. Go ahead, numbers, 80 to 250. They should always carry a simple carb source when they're exercising, regardless of what their finger stick was when they started. They need to have something with them. This is also when it's important to have a medical alert bracelet. So if you're a diabetic client, they like to go out and run, they need to have a medical alert bracelet so that if they're found somewhere, the people who find them have an idea what's going on with them. And then on exercise days, they need to monitor their glucose levels more carefully. They need to utilize proper foot care when exercising, which we'll talk about foot care more in a second. We talked about this a little bit. As complications develop, you may need to help them find an alternate exercise plan. Ideally, we're looking for 150 minutes per week of moderate aerobic exercise, divided into 3 workouts. So 150 divided by 3 workouts, at least over the week. We also would like for them to have a couple days of resistance training like weights. So ideally, we'd like them to do a little bit of something about 5 days a week.
It was contraindicated in some. Can I ask her a question?
They need to check glucose before, during, and after exercise. They need, go ahead, do you guys have a question?
Yes.
Okay.
When I was reading, I could be totally wrong, but weight training was contraindicated in one of the types of diabetes, right?
I haven't read, not to my knowledge, but I'm not saying I'm not wrong about that.
I thought I read that.
Okay, just curious. I'll find it.
A couple of the students thought they read it, but that seems to be pretty much paid, so.
The one time, and that's what I was going to say, the one time it is contraindicated is if they need to test for their urine first, and if they have ketones, they should not exercise.
That's right.
Could that
Thank you.
could that be it?
Yeah.
She thinks it probably is. Thank you.
Okay. Which that was where we were headed anyway. So they're gonna check their glucose before they exercise, make sure it's in the right window, they're gonna check their urine. And if they have ketones, they're not gonna exercise because basically if they have ketones, it tells us their body's not gonna be able to absorb glucose and feed those cells when they exercise. So if they've got positive ketones, they should not go ahead and exercise after that. Okay, foot care. So we kind of talked about changes in circulatory and nervous systems create a high risk for peripheral tissue damage, especially in the lower extremities. Clients can get little bitty wounds that they don't even feel. Poor circulation in the area leads to poor nutrition in the tissue for healing. Limited immunity can get there, so they get infected. Then sometimes that results in loss of limb amputations, and then their mortality rate increases after an amputation. So we're going to talk a lot about foot care here. This is a new slide, so take a picture of it or whatever you need to do. Sorry. I decided to put it in writing so you wouldn't have to write it all down though. So they should inspect and wash their feet daily. They should clean their feet daily. They should wear closed-toed, well-fitting shoes with socks to prevent injuries to the feet, even when they're indoors. So basically, if they're up and out of bed and walking around, they should have closed-toed shoes on with socks at all times. Ideally, your book said that they should have more than one pair of shoes so they can alternate. So like if one maybe rubs in one spot, so if they're alternating back and forth, they're not getting any kind of source from their actual shoes. Some diabetics are going to have a lot of sweat on their feet, and they may need to change their socks halfway through the day or in the evening, because any situation where we're wet, we have raw skin, anything like that is going to be serious for them. So much bigger deal for them, so we are very, very careful with their feet. Tight shoes can cause ulcerations, so their shoes should extend at least half an inch past their longest toe. They should avoid heels that are more than 2 inches. And if they will go shoe shopping later in the day, that will give them a better fit, basically. So so that they don't end up with shoes that are too small that are gonna run. They wanna bring new shoes in slowly, so we've all done that. You get a new pair of shoes and they're cute, so then you wanna wear them all day for 2 days, and that doesn't usually work out very well. So for them especially, because those blisters can turn into something bigger, they wanna break them in slowly, keep wearing their old shoes part of the time. They need to examine their shoes regularly for any damage that can lead to rubbing. Once again, remember, you get a rough spot inside your shoe, you're gonna feel it, and you're gonna take those off, they're not gonna feel that. So they've gotta actually visually inspect, put their hand down in their feel, have somebody else feel, and make sure there's nothing in the shoe, like a rock. Same thing with a rock. They get like some kind of rock or stick in their shoe, they're not necessarily gonna feel it until it's already damaged their foot, and they can't heal that injury. They should never go barefoot. We can already cover that. Change socks at least daily. 2 pairs of shoes. They should trim their toenails straight across to prevent developing those kind of ingrown toe injuries that get up in there and then they get those infected and lose those toes. Also remember, they can't feel very well, so they need to use warm water for bathing, and they need to test that water with like their wrist or something before they hop into it with their feet, because it could be scalding hot and they're not going to feel it in time to avoid damage, basically. So never be in hot water. Use warm or tepid water, and always check it before they put their feet in. If their feet feel cold, which can happen because they've got limited circulation going on, they need to wear socks rather than using like a heating pad or a hot water bottle or something like that, because once again, if it gets too hot, they're not going to feel that it's doing damage until it's too late. If they have any non-healing broken skin on their feet, they need to notify their provider so they can get that treated appropriately. And that may not always be like an injury, like we think about like a wound. It could also just be dry or crack, like major dryness or cracking, like in their heels or something like that, that could create an opening for microorganisms to get in there. Obviously, smoking cessation is going to help with foot care because they're going to have better circulation on their feet. And then your book talks, I don't have experience with this honestly, but your book talks about the fact that they can have an annual foot risk assessment from their provider that uses a little microfilament to test like how far up their foot or how well they can feel certain kinds of touches that will give us as healthcare professionals a better indicator of how at risk they are for a foot injury. We kind of already talked about neuropathic foot pain a little bit and some of the medicines that we can use for it. Your book also mentions using topical creams for it, like that have capsaicin in it. Can be one way. And capsaicin, I'm sorry if you don't have that on the slide, it's spelled CAPSAICIN. And some days, and you want to educate your patient, it'll take a few days, but that comes in a topical cream that might help with some of that pain. The other thing is that they're having foot pain when they're trying to lay in bed that's keeping them from sleeping, that you can get them a foot cradle that'll hold the blankets up off their foot in case that's kind of, because remember when we have that kind of neuropathy pain, it doesn't necessarily make sense for the stimuli. So like the weight of a blanket laying on their foot may cause them some kind of excruciating pain because those nerves are just damaged. And so sometimes for some clients that can cause them trouble sleeping. That's it for feet. So clients who are hospitalized are often going to experience increases in hyperglycemia, sometimes associated with whatever illness they have, sometimes because of changes in their diet and activity, or changing of their medication. Regardless of why they get it, if our clients in the hospital are hyperglycemic, they have reduced immunity, higher infection rates, longer hospital stays, increased rates of having to go to ICU, and greater mortality. So we want to get as good of control as we can of them when they're in the hospital. Hypoglycemia can sometimes also be an issue in the hospital. Most hospitals have a protocol for that, and we'll talk more about treatment in a little bit of hypoglycemia. I'm going to hit the hospital care stuff relatively quickly, but there are a few important things. Not super worried if they memorize ICU management. It's basically just that they'll often be on some kind of continuous infusion that has insulin in it to kind of just keep them at a continuous level. Surgery can be a major issue with diabetics. They're more likely to suffer complications, and nurses are often unsure about how to handle clients who are NPO, diabetic clients who are NPO. So for clients who are NPO for surgery, they should still get basal insulin, like their baseline glucose levels, because they still need some insulin to get sugar into those cells, right? I mean, otherwise their cells don't get any nourishment. So they still need that basal insulin. Any medications that we talked about that are food dependent would be held because they're not eating. And a similar thing, we're going to talk about sick days, and we'll have a similar theory on that too, which is they still need to take their insulin, like their baseline insulin, in order to allow their cells to get better, to get nourishment and get better and fight whatever's going on with them. If we withhold their insulin, then they can't get any glucose into their cells well. So we will withhold some other meds that are related to food, but not their insulin, and not their other meds that aren't related to food either. So pre-op, we want them to be off sulfonylureas for 1 day. Sulfonylureas, which it's that very first, it's on your very first slide. If you will just, they're included in the insulin stimulator section. So if you just write that, that would be easier for you to write. But some of those are sulfonylureas. For 1 day, they need to be off those for 1 day before surgery. They need to be off their metformin. This part says 24, but I think the part around metformin said 48, so something in that range before they get the anesthetic, and you need to not start them back on it until you know their kidneys are working well again, until they've had time to eliminate that anesthetic, so we don't overtax their kidneys. Oral meds are gonna be stopped the day of surgery. Other than the one we already talked about, but they're supposed to already be off of. And if we can keep their glucose levels around less than 200 in the timing around the surgery, we have reduced chance of infection, maximum chance of wound healing. So that's where we're aiming for, is to keep them under 200 during that perioperative period. When they go into surgery, they're typically going to have, again, an infusion that has glucose and insulin and everything to keep them at consistent levels. Another thing that's important here is kind of remembering that infection influences glucose levels. So if you may sometimes, in a post-op patient, if you see a glucose spike in someone who's been well controlled, it may be an early sign of infection that may precede them getting a fever. So it's something to pay attention to if they suddenly spike and you don't have a reason for that. See if there's anything else here. Obviously, there are going to be a higher potential for cardiovascular complications after surgery because of the cardiovascular issues that go along with diabetes. So we want to cardiac monitor them. And they will need carbs in their immediate post-op period. So when we start them back on fluid, like those initial kind of clear liquid when they come out of surgery and then full liquid things, we're not worried about making those sugar-free right after surgery. Those can be regular liquids until we get them back up to eating real food, solid food, and then we're gonna back them back down to sugar-free liquids when they're eating solid food again. And that's kind of it for that section. I think really, our earlier slide said 48. Right there in the book it said 24, but I would tend towards the 48 probably.
For metformin.
And these are kind of those individual, like kind of care for those individual microvascular changes, but we've kind of talked about some of those. In terms of diabetic retinopathy, you're kind of control glucose, blood pressure, lipids. In terms of management, things like large print materials, getting them assistive devices for their vision, improving lighting and contrast, sometimes like improving the contrast. One of the things you want to keep in mind is like with educational handouts that you might send home with them, remember that their visual acuity might be changed to make sure it's something they can actually read and see, or it's not going to do them any good when they go home. Check in with insulin, they've got to be able to safely drop and administer, and that's going to change. So, it's not just that first time they get diagnosed when they leave the hospital, but during annual visits and things like that, we need to be continually assessing that their vision is still where they're capable of doing that. There are some devices that can be used. Like I said, you can't use the pre-filled syringes for that, but there are some devices that will provide like an auditory like click for every unit or different things like that that they could use if they're having visual issues. There are also meters like glucometers that have large display or auditory things. And then the next two slides kind of just show you what vision is like with retinopathy. So you can see what a huge difference it makes in that picture there. Neuropathy, we kind of touched on all that. We talked about foot care, that, wound care, we need to be diligent in our wound care. They need to report any kind of wounds that aren't healing. Talked a little bit about meds for pain management. So that one's kind of covered. Nephropathy, we kind of touched on these things. Controlling blood glucose, obviously, prevents progression. The two meds we talked about, ACE inhibitors, angiotensin receptor blockers can help with blood pressure control and protect the kidney. Obviously, if they'll stop smoking, that also helps us out. We need to evaluate their kidney function annually. For any type 2, also any diabetic client who's pregnant, and anyone who's been type 1 for more than 5 years should have an annual check of their kidney function. Your clients need to know that other agents can be nephrotoxic, so can increase the damage to their kidney, so they need to make sure all prescribers know that they're diabetic and know what medicines they're on. Interestingly, one of the large over-the-counter meds is NSAIDs. Ibuprofen and naproxen can damage kidneys too. So diabetic clients would be best avoiding those and maybe using Tylenol instead as long as liver function's good. Use caution with contrast agents, even if they're not on metformin. The kidney damage can cause them to have difficulty eliminating those agents. They're going to clear all those agents slowly. They're going to clear as in get out of their system, metabolize more slowly. Contrast agents, anesthetics, things like that, all medicines to some, any medicine that goes through the kidneys is going to clear slower for these clients over time. Then we talked a little bit about dialysis. So the next question is, why is controlling blood glucose levels important? Ina, this is you.
In any situation?
Just in general.
Oh, I see. There's answers there. Never mind.
We're going with A.
Okay, sounds good to me. These are questions I stole from Mrs. Martinez, by the way. Okay, self-management. So, daily glucose management is the key to promoting the highest level of health possible for these clients and preventing short and long-term complications. So client education is key. The client and their support persons are the ones who are going to be responsible for managing the disorder on a daily basis. So it's important to use your team. Remember adult education concepts. Remember, like, active learners, they learn things better if they're active. They are motivated. You got to find the things that motivate them, that are relevant to their lives. You want to give them the information they can use immediately. Those are the kinds of things that are going to help them to learn better. Assess readiness to learn. Be sure you're teaching them on their health literacy level. A lot of this is just review from teaching and learning. Start with their survival skills by discharge, which we'll look at a slide for those. And then later you're going to add in the teaching at follow-up visits. So even just sitting here today, there's so much to learn about diabetes. It's impossible for them in the emotional turmoil that's going on. So they're also having to change their diet to learn all the things they need to learn in one visit. So we're going to talk about kind of what is absolutely necessary, and that's the next slide. Here's what you need them to know by discharge. Some of that other stuff, and then we're just going to continue to teach them when we see them for follow-up out in the community care too. So this is your priority info before discharge. They need to have a simple understanding of diabetes. Remember, anything you tell them or write for them needs to be on the 6th grade literacy level or below for them to really be able to understand it. Like we talk about the long-term importance of glucose control, why it's important that on a daily basis they're controlling their glucose, how it will affect them in the long run. They need to know how to take their meds, whether they're insulin or oral. They need to know that they need to check with their provider or pharmacist before taking any over-the-counter meds, herbal meds, adding any new prescriptions. Need to be diligent in carrying their med list with them. We're going to talk in a second about hypoglycemia, but they've got to basically know what it looks like, know how to treat it. We'll kind of talk about a protocol for that next. They need to know about hyperglycemia, prevention, recognition, treatment, kind of the stuff we talked about on Tuesday with that. They need some basic diet info, so decreasing simple carbs and fat, increasing fibers and complex carbs, kind of the basic stuff leading up to hopefully following up with a dietitian to develop their own individualized plan. They need to know how to monitor glucose and ketones. They need to know the sick day rules, which we're going to go over. We can probably hit that real quick. So sick day rules are in your book on page 1314, chart 64-8. Just so you don't have to write everything down, you can go look at it later. But basically, this is what they involve. They need to notify their provider that they're sick. They need to check their finger stick every 4 hours while they are sick. They need to check for ketones if their glucose is over 240. So if they're high, they need to be checking their urine for ketones. They need to continue to take their meds, like we said, because eliminating their insulin is just going to make them sicker. If their glucose stays in the target range, they need to drink 8 to 12 ounces of calorie-free, caffeine-free liquid every hour to keep them hydrated. Because remember, dehydration goes along with hyperglycemia, and sickness throws our glucose off. So dehydration is going to be a major issue with our diabetic patients when they're sick, as well as hypoglycemia. If their glucose is falling below the target range, like they're not able to eat or drink like they normally would, then they should start drinking fluids that contain sugar and electrolytes, such as pop, sports drinks, diluted fruit juice. Same amounts, 8 to 12 ounces every hour to keep themselves hydrated. They should be trying to eat meals at the regular times they normally would. If they can't take in solid carbohydrates, then they need to substitute an approximate equal amount of liquid carbohydrates. So like they could be like glucose or different things like that they would be substituting in. What do they need to report to their PCP? And I think this is in that same table, but I could be wrong the way I have it written on here. So if they have persistent nausea and vomiting and they cannot take in food or fluid for more than 1 to 2 days, they need to tell their provider. Is that on that table? Okay. If they have moderate or large ketones, or they have ketones for more than 24 hours, they need to notify their provider. If their glucose continues to stay above 250, in spite of the fact that they've tried to treat it twice, they need to notify their provider. If their temp is greater than 101.5 or lasts more than 24 hours. And then they'll treat any kind of nausea, vomiting, diarrhea, or fever as advised by their PCP. And we didn't get into those acute complications, but that's part of the reason the sick day management is so important, is because that hyperglycemia, dehydration combo can cause some really severe and fatal complications for them. And once those things start, the fatality rate is pretty high on them. So that's why we worry so much about their management on sick days, is to keep them from getting sicker on those days. Besides sick days, they're also going to want to contact their primary care physician if they have signs that their tissue is not perfusing well, if they're developing cardiac problems, exercise fatigue that's worsening, decreases in perfusion, things like that. If they have signs of infection, local or systemic, they're going to want to get on that really quickly, because like we talked about, sometimes we lose limbs for that. Systemic infections can really throw our glucose off, and then we just get sicker. They can get septic pretty quickly. We talked about long-term education. A few more minutes, we'll hit this hyperglycemia. We're actually fairly close, because some of those last ones you can kind of just read. So, and I think some of you guys might have looked at this when you were working on your projects the other day, but symptoms here of hypo and hyperglycemia, it's going to be important that you can differentiate between the two. Definitely need to know these. Hypoglycemic symptoms start when glucose falls below 70. But that assumes like a normal baseline level. Some clients are going to be symptomatic higher than that if they're used to, if they're used to walking around at 300 or 400, then they're going to feel achy long before they hit 70. Mild levels can be self-managed by the client, such as with a carb snack. And I don't know if I wrote on here, there's a good table. Okay, so page 1310, chart 64-7. I think if I have this written down right, is the home management info for hypoglycemia, and it very specifically tells them, here are the snacks that you should take. So take in this snack, and I think the store that had this kind of covered it the other day too, but they're gonna take in that snack. Liquid form, if they're really low, liquid forms are preferred, obviously, just because that's gonna lift them up higher faster than if they have to break down some kind of food form. But you don't wanna overdo. So stick to the snack amount, recheck in 15 minutes. And then if they're still under 60, they're gonna re-snack again. Recheck again in 15 minutes. Initially, in the initial treatment, we want the carbs because we want that glucose spike. And then normally, when we're talking about their normal eating, we want proteins, fats, complex carbs. But in this particular case, we want simple carbs, no proteins or fats that are gonna slow the breakdown of those foods. Once they get in their target range, they need to add a more complex snack if they're more than an hour away from a meal. So once we get them up where we want them, we need them to eat something complex to keep them there, unless they're gonna eat a meal soon. If they're under 20, they're gonna need a support person to administer glucagon injection, and they're gonna need medical follow-up. The support person needs to be educated that vomiting is a common side effect of that infection. So if the person is unconscious, like they're so low that they're unconscious, they're gonna have to watch them so they don't vomit and aspirate. So turn them on their side, keep their head elevated, things like that. The effects of the glucagon are short-lived, so they're gonna have to follow up as soon as they become conscious with snacks and medical attention. And then they need a plan to prevent it, basically. If they're getting that low, there's something going on, and we need to figure out why, so that it doesn't happen again, because if they do that by themselves and they're so out of it that they can't treat it themselves, they'll die if there's nobody there to treat it for them. So we wanna prevent that. Trying to see if there's anything else we need to talk about on this one. I think that pretty much covers that one. Okay, and still want to cover this for me very well too. These are the common, this is a new slide, but these are the common causes of hypoglycemia. Basically, they have excessive insulin. Can happen if their insulin sensitivities change, if they lose weight, if they get an infection, something like that. If they change brands of insulin, that can change too. Food, changes in the timing of their food, things like that can cause hypoglycemia. We kind of talked already about exercise. It increases muscle energy demands for several hours, even after completing the exercise, especially problematic sometimes for type 1 clients, so they really have to plan around that. Check finger sticks, check ketones, time their exercise for after a snack or a meal and away from their insulin peak. So exercising and insulin peak can also cause hypoglycemia, and then alcohol intake. We kind of covered this too, but basically alcohol inhibits the production of glucose by the liver. So the initial increase happens as they're digesting it, but that's followed by a crash as the liver decreases production. So they'll actually end up being hypoglycemic. So they need to drink any alcohol with meal times or immediately after meals. Patient family members need a plan. They need to have their snack with them. And I had some other things that can affect hypoglycemia, but Stillwater covered them all the other day. Hormonal changes, metabolic insulin, that kind of stuff when they talked about those. That meal times need to be kept within 30 minutes of usual if it's at all possible. So we want them to, in theory, always eat within 30 minutes of kind of have a window where they always eat about the same time. Psychosocial. Let's see where we're at here. Then we need to do, there's not much left. Psychosocial, I think these are gonna kind of make sense to you. Lots of losses, they're not gonna be able to eat what they like necessarily, losing sensation, especially if they're also losing cognitive sexuality function. So lots of loss that goes along with that, lots of changes in lifestyle and family dynamics. One of the things that sometimes happens is whoever the meal preparer is gets really controlling with them about what they can and can't eat. So it can sometimes change the dynamics of the relationship in that. So they, then they're, okay, like my dad keeps a stash of candy bars in the warehouse away from my mom because she won't let him eat sugar and that kind of thing. So just from personal experience, it can change some family dynamics. Can cause some financial hardship because there's lots of costs associated. As much as possible, you can help them restore a sense of control by helping them incorporate their favorite foods or variations of their favorite foods into their diet. Create a long-term personalized plan for them, help them find a diabetes educator, a dietitian, a support group maybe to help them with those. Cultural considerations are on that next slide, and we kind of already talked through those. There's really, you can read those. There's nothing I have to add to that one. Then there's also age considerations. For the most part, we kind of already covered these. They're going to be less aware of those hypoglycemic and hyperglycemic symptoms, so it's helpful to have somebody kind of monitor those for them and really teach them because they may not notice them as quickly. They may have difficulty obtaining or preparing healthy food. Keep those things in mind. Dental issues can impair their intake and may influence their food choices. Obviously, like lean meats, fresh veggies, those things are harder to chew than simple carbs. So if they're having trouble with their teeth, that's going to influence that. They may not be able to control what they eat if they're in a facility or something like that. They may just have to eat whatever they're fed. So that's something to keep in mind too. And they need to add activity slowly. What does it say here? They want to do low intensity, less than 10 minutes at a time, and be realistic in what you expect them to change at an older age. If they've been eating that way for 65, 70 years, it's going to be very difficult for them to change the way that they eat or to give up the things that they've loved for that whole time. So be realistic in what you're asking them for. The last slide is evaluation. Oops, there. Examples. Those are basically just goal examples to kind of give you some examples of what you might be looking for in your clients. So you want them to maintain an A1C below 7, avoid chronic complications, have a neuropathy pain below 2, just kind of some examples of how you might evaluate the diabetic plan for your client. I think we made it. Do you guys have questions? That was a lot. I'm sorry.
Mrs. Haig,
Yes.
I need to make a real quick request of the Enid students.
Okay.
Tomorrow with first simulations, and when I looked at on the Sign Up Genius, I only have 2 students listed at 8:30. If I could get any Enid student to sign up with them, that would make a better learning experience for those 2. So if you are available, jump in and help out your classmates who have already committed to that time, and then I will see all of you in Enid in the morning.
Okay, thank you, Mr. Brown.